Hi, everybody. Again, Dr. Patrick Powell, here to talk to you again this week about sex addiction. This week, we're covering some of the models that really focus on the etiology or the cause of sexual addiction. There are quite a few, so we're going to go and get started, and we'll compare and contrast a few models. What I really hope you see is how they've developed over time. At the end of this, I'm going to introduce my model, which I view as an integrated model. That includes both a biological, a social, and a psychological aspect. But in order to understand that model, I think it's important that you understand how we got there. So let's take a look. I'm going to open up my screen to you all. Alrighty. So, in terms of causal models, we're going to discuss some of the sociocultural influences. We're going to discuss some of the models that focus on sexual addiction really being poor coping skills for stress, responses to traumatic events, biological influences, and we're going to pay particular attention when we get there to how dopamine plays a part in terms of maintaining sexual addiction, the neuroscience, neural reward, and previous models of sex addiction. And finally, we'll talk about the model that I've developed that integrates a bit from quite a few of these categories. So, as we go into this section, I want you to take just a moment, and again, feel free to pause the video to ask yourself how you think sex addiction develops. What are the causal factors? What are the processes? Well, assuming you've paused it or had a moment to think about it, there really is no simple, easy answer. Really, when we look at sex addiction, we see multiple causal factors. As a result, our treatment plan has to be multifaceted. But again, just in terms of the cause or the etiology, multiple factors impact the development of sexual addiction. It is worth noting that, again, because of the disagreement in the field regarding whether or not sexual addiction even exists, there is a large discrepancy between various models of etiology. Let's talk for just a minute about social cultural influences. When we talk about what influences us as individuals in the most significant way, really our family is the most significant factor. That's the organization or the group that you are raised by, that you have the most contact with. So in terms of early development, your family is the most significant influence that exists. When we talk about culture, people tend to think about an ethnic culture or something along those lines, or even a culture among race. But uh, really, when we're talking about culture in terms of families, each family has their own culture. I'm sure if you think back to it, you can think about some rituals that were present in your family. For example, my family, on every Christmas, we opened Christmas presents. Every Halloween, we walked around and trick-or-treated, that sort of thing. But then there are often unspoken influences as well, and unspoken rituals. For example, if you have one family member that's very needy, maybe impaired, families often bend to work with that family member or not mention his or her disease or issue. So every family is a culture. And again, family is the primary influential culture when we're individuals. If this were a family family therapy course, we could talk about multi-generational family therapy and how we transmit some of our issues and some of our interactions generation by generation. But um, we're only going to mention that in this context, just to denote that it's not unheard of to see sexual addiction in family members and then later on in their children. It's not unheard of to look at a child's view on, or an individual's view on sexuality in general, and look back and see some level of that view being informed by what their parents told them, how their parents disciplined them around sex, how their parents had healthy sexual conversations, or unhealthy sexual conversations. Again, our idea of sex is directly influenced by our family. We can learn to view sex in a healthy way, but we can also learn to view sex in an unhealthy way. A couple of things I want to point out just from the research field. It's worth noting that the majority of individuals with sexual addiction were raised by individuals with various addictions. I think what that speaks to is the addictive personality, which is a concept that you hear of. What that term refers to are individuals who may switch addictions. They may be addicted to one thing and then switch to another. For example, an individual may be addicted to cigarettes and then may switch to alcohol, or vice versa. Carnes in 2001 noted that only 13% of individuals with sexual addiction came from a family without addictions. I want you to think about that for a moment. That is a staggering 87% of individuals with sexual addiction, in that study at least, had a family member with addictions. As you hear that, what I hope you start to think about are the messages that are being transmitted from adult to child. Are they encouraging chemical or other addictions? Are they, even if they're not encouraging it, are they not disapproving of it? Are they not paying attention to that child? Does that child learn to meet his or her needs by maybe modeling after whatever mom or dad did? Researchers at the Augustine Fellowship, way back in '86, conducting a study, specifically noting that roughly 86.8% of individuals with sexual addiction in their sample were from detached families, meaning families where there was no emotional connectivity. And 77% of that sample were from families that were very rigid, where people had very rigid boundaries and rigid rules. Again, what I hope you take away from that, and this is where the field will go in the future, hopefully. What I hope you take away from that is there is some correlation between unhealthy family patterns and addictions. And whether we're talking specifically about sexual addictions or broader addictions, I think that piece is relatively well understood. I think with sexual addictions, one thing we may want to focus on, we'll talk about this a bit later on, is if a family is not there to help a child learn how to cope, how does he or she cope? Where do they learn that? Sometimes they learn about that through discussing sex or other sexual practices related to their family. Just one more comment. Large family size, unemployment, any family disruption, losing a sibling, addictive behaviors in parents, divorce of parents, low levels of education in parents. These have all been documented in association with risky sexual behaviors. Not necessarily sexual addiction, but risky sexual behaviors. Because again, if no one is there to model healthy sexuality, we have to kind of find that out on our own. And sometimes what we find out or what we develop or how we develop is not healthy. Let's move on and talk about another arena of theory related to sexual addiction. When people repeat activities, they do so because it tends to reduce stress, it relieves you from boredom, it can be pleasurable, and it helps you cope. When we talk about sexual addiction, those four are all prevalent. When people with sexual addiction enact sex or engage in sexual behavior, it does reduce the anxiety. It definitely reduces boredom. It's pleasurable. And sometimes people will engage in sex because it's the only tool they have in their tool bag. And again, it helps them cope. It helps them feel some level of emotional calmness. Black et al. In 1997 noted that some mood states can trigger sexual behavior in 96% of that clinical population. Roughly 67% of that population, when they felt sad or depressed, engaged in sexual behavior. When 54% of that population were happy, they engaged in sexual behavior. When 46% of that population when 46% of that population felt lonely, they engaged in sexual behavior. What I hope you see as you look at this study and as you listen is there is often a link between what we feel and how we try to resolve it. Some individuals, for multiple reasons, will try to resolve it through sexual activity. And the more a person does that, the more that becomes your coping skill, the more you're going to use that tool. And then when you need that tool, the more often you're going to use it. The authors noted that individuals with limited coping skills tend to be more prone to sexual addiction. Horvath noted again, I think I just stated this, but if an individual only has a couple of skills to address his or her boredom, sadness, frustration, he or she may enact behaviors, sex, gambling, shoplifting, on a more frequent basis because that becomes the coping skill. So, I want to go back to the family environment we were talking a minute. When we talk about learning our coping skills, by and large, we learn that from family. Our family are the individuals that teach us how to cope when we're sad, upset, or distressed. But if you're in one of the environments we just talked about, with rigid families or detached families, you may not learn healthy coping skills. Castle in 1998 noted that some individuals spend a majority of their childhood trying to soothe their parents that don't have coping skills. When that happens, this child is not focusing on his or her own development of coping skills. Also, if a parent is incredibly upset all the time, that parent is not going to be in a stable place, at least in terms of teaching this child, this is how we cope with stress. So not only is there a lack of role fulfillment, there's also an aspect of modeling when it comes to a parent who should be stable and who should be able to manage his or her own distress. Children sometimes observe, and if there are any behavioral therapists out there, this would make perfect sense to you. They observe a parent not handling their stress in the best way, and sometimes they mimic that coping mechanism. As an adolescent or an adult, the individual becomes unable to self-soothe, and they can no longer find a parent to help them cope. He or she looks for external solutions to mimic pain. And for some people, that's where sex comes in. And that's where sexual addiction becomes that coping skill, because sex is an instant gratifier, but it is transitory. It's only there for the moment. And if you have no other skills, again, you're going to go back to the one skill you have. Merkovitz and Roloff described two sexual addiction etiology perspectives. We're going to focus more on one than the other. With the anxiety-based model, sexual desire is activated by anxiety states, including low self-confidence, loneliness. That person interprets that as a need for sex. Reducing anxiety is then linked to sexual behavior through early learning processes. So this individual learns to pair sex with anxiety. And anxiety is a natural part of life. We're going to feel that throughout all of our lives. So, if an individual learns to pair sex with anxiety, they are setting themselves up for having to engage in sexuality quite frequently. When anxiety levels increase, a need to reduce it through some kind of sexual behavior becomes very adamant and very strong. However, when an individual again engages in sexual activity, it's transitory. It dissipates, and an individual finds him or herself needing to engage in sexual activity again. Those same authors also noted that depression is also a model for sexual compulsivity. And they stated that some individuals with depression find themselves being less worried about the consequences of their action. What they're essentially saying is individuals with depression have lower levels of impulse control and engage in heightened sexuality due to low levels of impulse control. Let's move on and talk about a couple of other models. As you can see, looking in time, these are chronological presentations. So you can see, well, except for 2007, you can see Goodman here. We're going to talk about Goodman for just a moment in this context in terms of coping skills, and then we're going to look at the actual models, or some of the other models. Goodman defines sexual addiction as a disorder in which a behavior that can function both to produce pleasure and provide escape from internal discomfort is employed in a pattern characterized by recurrent failure to control the behavior and continuation of the behavior despite significant consequences. Goodman's definition recognizes that people try to escape from discomfort with sex, and that becomes a pattern for individuals. We spoke a minute ago about how detached or rigid families or emotionally anxious or upset individuals don't often provide the guidance for healthy sexuality with their children. Trauma is an extra additional factor that can impact that entire process. When we think about children that were sexually abused, and it's worth noting that Carnes found that 82% of individuals with sexual addiction in that sample reported being sexually abused. When we see children who are sexually abused, there are a couple of things that are happening there. They begin to attach sometimes love with sexual interaction, and oftentimes their boundaries of what healthy sexuality is are really diminished, really damaged. Moving on, opiates, Fitzgerald and Froh noted a strong predictive correlation between a childhood history of abuse and later sexual addiction. I don't think we can overestimate the level of impact that child sexual abuse can have on an individual in any number of ways, including sexual addiction. Abusive experiences during childhood or maltreatment can often result in uncontrollable sexual behavior. Littleton, Breitkopf, and Berenson. Again, you're seeing multiple researchers who are seeing a clear link between early childhood sexual trauma and later sexual addiction. Cateshold noted that early trauma, such as physical, emotional, or sexual abuse, has been shown to impact neurodevelopment, which in turn has been associated with sexual behavior problems. We'll talk about the biological aspect of neurodevelopment and sexual behavior issues here in a bit, but I think it's worth noting that Cateshold at least expanded early trauma from sexual trauma to emotional and physical abuse. I think it's reasonable to assume that neglect can also be considered in there. You know, when we look at biological influences for sex abuse, there are multiple theories. I think it's worth noting that, again, I mentioned this the last time we spoke. As individuals, we have different levels of sexual activity. Some of us have lower levels. Some of us have more frequent levels. Some people enjoy sex much less than others. Some people enjoy it more than others. Your brain and your neurodevelopment impacts your ability to moderate sexual impulses. Davis et al. Noted that the medial prefrontal cortex, that's the component of our frontal cortex responsible for making decisions, can be impacted by lesions, resulting in some compulsive sexual behavior. Now, this is by no means meant to impact that all individuals with compulsive sexual behavior have brain lesions or anything like that. Davis et al. Merely noted that's one potential factor. Svercik in 2009 noted that brain abnormalities, and you'll see these sometimes caused with various neurological difficulties, can result in sex addiction. We may talk about that a little bit more later on, but essentially when you have any of these brain abnormalities, it can impact your neurochemicals in any number of ways. It can also impact your impulse control. And much like, I'll add this as an additional comment, but it can impact your level of self-control. I want to add something that I did not type here, but when we see mania, and I know I spoke about this last time, but when we see mania, we do see heightened degrees of sexuality because, again, there's low levels of impulse control, and that is evident not only in heightened degrees of sexuality, but individuals with mania are also more prone to do dangerous things because, again, that level of impulse control is just low. So when we see brain abnormalities, it is not uncommon for people to have heightened degrees of sexuality. Prover, and I want to speak about this for a moment because this is really where the heart of the behavioral addictions field ties into addiction. Noted that with behavioral addictions, we have dopamine receptors that are activated during sex. When our dopamine receptors are activated, we have feelings of pleasure and euphoria. An individual with sexual addiction or any other behavioral disorder can really quickly experience sex, feel shame about that sex, and as a result, feel a need to get another dopamine hit and crave more sex. So it becomes a repeated cycle in terms of that dopamine and that feeling good or want to feel good, want to feel pleasure in the face of feeling shamed or bad. I just spoke about this to a little bit, but I do want to speak about this for just a bit more. You know, we're wired to promote activities that are pleasurable and that really result in our long-term survival. If you think about sex, that's geared towards our long-term survival. Eating, sleeping, we are hardwired to engage in activities that result in our longitude as a species. However, it's worth noting that that same process, that same mechanism of neurological reward through dopamine and other factors can impact individuals when it's used too often. Again, I know Proverb just spoke about this, but I want to reiterate, sexual encounters can trigger the relapse of dopamine. And again, that can result in a heightened feeling of elation, contentment, and happiness. When an individual is in a really bad place, that may seem like something that's an automatic go-to. These sensations encourage you to again and again pursue sexual experiences. That piece is the piece that is similar to chemical addiction. Sure, we're not talking about brain rewiring in the way that we do with chemical addictions, but there is a neurological aspect to behavioral addictions and to sex addiction in particular for this conversation. Okay, I think I just spoke about this. So let's actually look at some of the models. We talked about some of the causal factors. Let's look at specific models that we've seen over the time. And as I mentioned earlier, these are in a chronological order, so you can get an idea of how our understanding of the causality of sex addiction has developed over time. In 1978, Reed and Blaine described a 4-stage process for addictive sexuality. Notice they're not saying sexual addiction, addictive sexuality. But their model is still very relevant today. It includes both compulsive and impulsive aspects, which are components of sexual addiction. So obsession, in response to existential difficulties, individuals become totally absorbed by preoccupation. So when an individual feels stressed or upset, he or she focuses on sex as a means to soothe. Ritualization, an individual develops rituals that precede behavior. That may mean going to the store to buy pornography, going to the corner to pursue prostitutes. In this modern day and age, hitting up Tinder or Grindr or that sort of thing to find people to have sex with, but some level of ritualization. Actual sexual activity, which in a moment produces that feeling of euphoria, that feeling of things are okay, and then despair, feeling as though a person was not able to control themselves again. And it is a cycle, and it leads right back to obsession. So that's Reed and Blaine's model. In 1983, Carnes proposed his model of sex addiction, and that's really the first time we start to see this phrase, sex addiction. In this model, sexual behavior can be repetitively misused as self-medication to manage dysphoric, unhappy mood states. This can lead to an escalation or progression of sexual behaviors, increased risk-taking. So an individual may, instead of feeling as though being with a partner sexually is not meeting his or her needs, he or she may try to have 2 partners, 3 partners, 4 partners, or lead to areas that are progressively dangerous. Feel a loss of control, have any number of psychosocial consequences, including feeling depression or shame. Finally, hit a withdrawal state where he or she feels anxious and nervous, and may experience other addictions as well. Moving forward in time, Barth and Kinder bring about hypersexual disorder. Again, the focus on this is heightened levels of sexuality. At that time, they're focusing on this being an impulse control disorder. An individual feels an increased sense of tension or arousal before committing the act, and then experiences pleasure and gratification after the act is committed. In 1993, Anthony and Hollander theorized that hypersexual disorder might be related to OCSD. I think if you look at the DSM history, you start to see hypersexual disorder hinted at in previous editions of the DSM-5, specifically in the DSM-3. But again, it's not in our current manual. Finally, in 1999, Bancroft proposed the dual control model of sex addiction. So we're jumping back to sex addiction, leaving hypersexuality behind for a moment. In this model, sexual response is dependent on the balance of 2 systems in your brain: your sexual excitement system and your sexual inhibition system. Both of those 2 factors, whether they're functioning healthy or whether one function is impacted negatively or limited, will impact your sexual desire, positive or lack of, or your sexual control, again, positive or lack of. Individuals with an unusually high propensity for excitement and low propensity for inhibition are more likely to engage in high-risk sexual behaviors or other problematic sexual behaviors. In 2005, we see Griffith's component model of addiction that has specific components. Now, you'll notice that in contrast to Reed and Blaine's model, this model, instead of focusing on a stage approach, focuses on specific components that you typically see in sexual addiction. Salience. Sexual behavior becomes the most important activity in the person's life. Mood modification. Subjective experience that individuals report as a consequence of engaging in sexual-related behaviors. Some people feel awesome afterwards. Tolerance. People feel a need to have heightened degrees of sexuality because they reach a point where what they've been doing is not having the same effect. Withdrawal. Feeling irritable, depressed, mood when not, or depressed or anxious when not having sex. Conflict. Having conflict with others due to this person's pursuit of sexual activities. And finally, relapse. When an individual feels that he or she has conquered their sexual addiction, reverting back to a point where they're engaging in unwanted sexual behaviors. So again, Griffith's model, I personally appreciate because, one of the things that we know about addictions in this day and age is that it's common for people to go all the way through this model and then revert right back to feeling helpless, feeling as though they can't control their sexual behavior because they relapsed. So I appreciate that this model is not as linear as some other models. So we talked for a bit about the some of the models that I look at in the field as being really hallmark models, and we've talked about some of the causal factors. I'd like to talk for just a minute about my proposed model of sexual addiction. Again, that model focuses on some of what we've seen in different models here, but it also connects some of those causal factors. And in particular, because sexual addiction is a behavioral addiction, we focus on the dopamine piece a little bit later in the end. But let's just talk about it for a minute. Early childhood experiences, whether that's neglect, sexual or physical abuse, can result in an individual who feels immense shame. On top of that, he or she may not learn how to develop their own emotions because they may have had any number of hectic or outright erratic or dangerous situations in their home. Children may not have had the ability to have a parent who could soothe, cope, and teach them coping skills. As a result, those individuals will mature lacking the ability to self-cope. When they are unable to self-cope, they're going to look for external means. Sex is one possible mean. I do want to comment that the drive for sexual fulfillment, that comes from an unmet psychological need to relieve anxiety, depression, any number of negative mood states or emotional states. Sexual addiction does not come from, well, obviously it doesn't come from a place of normal, healthy sexuality where you simply want intimacy or closeness. Sexual addiction comes from a lack of ability to self-maintain. As an individual moves through life, he or she is likely to continue to feel shame about what happened, either early as a child, or about his or her inability to connect with others in the current state, or about his or her inability to control their sexual acts as an adult. This can be a real challenge for individuals who have been sexually abused. Those children in particular, and I think this is evidenced pretty well by Karn's earlier study, those children may clearly associate soothing and connection with sexuality. Sex can become a means of connecting with others regardless of how shallow it becomes. As that produces a rewarding effect, an individual may become more and more preoccupied with sexual thoughts, fantasies, and efforts to obtain sex. An individual may also be triggered into those states as he or she moves through life, and especially as he or she has conflict with others regarding any number of relationship factors, including sexuality, but also just personal factors in terms of hunger, boredom, loneliness. Again, this person may not have many coping skills because they were not taught them when they should have. Again, some individuals will manage their gratification or their needs by sexual gratification. You'll see some individuals who will make very obvious attempts at sexual interaction with others, texting, attempting to develop superficial sexual relationships, flirting, acting needless or helpy. Over time, that behavior can become compulsive. Again, there's a biological component. When we find a behavior or something that results in pleasure, we do that more often. The more we do that, the more we have that dopamine release, the more we reinforce this cycle of we're going to meet our distress by trying to reach euphoria by way of sexual activity. The more distressing and the more upsetting this pattern becomes, the more likely a person is to repeat it. I think anyone that's worked with a client with addiction and who has talked to those individuals will recognize that the longer an individual has to deal with his or her addiction, especially in relating that to others, the more stressed or anxious he or she feels about that addiction. Further, when individuals decide to attempt to remediate sexual addiction, many people are not successful because, again, they don't have other tools in that tool bag. When they're not successful, that further emphasizes failure rate. That further emphasizes that person's potential identity as a failure. That further emphasizes shame. That further emphasizes guilt. As a result, that person may give up on treatment, and they may they may attempt to weather those emotions through further sexual activity. So we've talked a bit about my model. Again, my model integrates quite a few causal factors and really the biological aspect that we do see with behavioral addictions. I will be curious what you think about that as you sit down and process what we talked about this week. Next week, we are going to transition and talk about some specific risk factors. So I look forward to talking with you all then. In the meantime, best wishes, everyone, and I'll see you soon.